Hello, and welcome to the Texas Rex Educational Series. This session is being recorded and will be posted on the texasrex.org webinars page if you want to review the content or share the information with your friends and colleagues. Our speaker today, Dr. Susan Fenton, will be speaking about ICD-10, what you should be doing to prepare. All attendees have been muted to block out background noise. If you have questions for our speaker, please post them in the chat block of the GoToWebinar pane. Your questions will be read to the presenter at the end of the presentation. If we are unable to answer your question during the allotted time, you will receive an answer via email. First, some information about our speaker. Dr. Fenton is an assistant professor at the University of Texas School of Biomedical Informatics, where she teaches regarding the health informatics standards and health informatics safety and security, among other topics. Dr. Fenton has led multiple grants, some multi-million-dollar, related to workforce training and ICD-10. She is currently co-PI on a pilot study examining the use of industrial engineering techniques for addressing the causes of catheter-associated urinary tract infections. Her textbook, Introduction to Health Informatics, co-edited with Mrs. Sue Bitterman, was published by AHIMA Press in July of 2013. Dr. Fenton wrote 2 chapters and co-authored 5 additional chapters. Dr. Fenton was recently elected to the AHIMA Council on Excellence in Education, serving from 2014 to 2017. Dr. Fenton has worked in the health information management field for 25 years, including as a researcher and practice leader at the American Health Information Management Association, as well as Director of Health Information Management for 6 years in the Veterans Health Administration headquarters. She received the 2012 AHIMA Triumph Award for Research. Dr. Fenton holds a PhD in Health Services Research from the Texas A&M School of Rural Public Health, with a Master's of Business Administration from the University of Houston and a Bachelor of Science in Health Information Management from UTMB in Galveston. Thank you for joining us, and I will now turn over the webinar to Dr. Susan Fenton. Dr. Fenton, the presentation is yours.
Good afternoon, everyone. And hang on just a second while I get my screen set up so that you can see the slides. Okay, hello everyone and welcome. I'm really happy to be here today. Thank you to the Texas Regional Extension Centers for inviting me to speak. This is a subject that's near and dear to my heart and one I enjoy talking about. So let's get started. So ICD-10-CM/PCS, I'm going to provide an overview today of ICD-10-CM-PCS and the regulation, when and where it's required, an introduction to planning for conversion, including some training at the end of the slides. I do have some links out to some training that you can go to if necessary. I'm also going to review projected clinical documentation needs related to ICD-10. So if we're going to this more detailed classification system, what changes might you need to make in your clinical documentation? And then give you a view into some studies I've done of the anticipated impact on your longitudinal data. So as you're trying to trend or report quality measures, what might you expect? So we'll start with the definitions. We have the International Classification of Diseases, 10th edition, clinical modification, so that's the ICD-10-CM. That is promulgated or controlled by the National Center for Health Statistics. They are our collaborating center to the World Health Organization, and they ensure that the clinical modification used in the United States maps back to the ICD-10 that is promulgated by the World Health Organization. Then we also have the International Classification of Diseases 10th Edition Procedure Coding System, PCS, which is managed by the Centers for Medicare and Medicaid Services, and there's the link there. Both of these are publicly available, free. You can download files from these websites with all of the codes in them. Of course, that's not as nice as the code books, but if you're just looking for the codes, you can get to those. So the new federal regulations, the final regulations were released now almost, a little over 5 years ago. And that was when we first heard that they were going to want to change the standards. They were effective March 17th of 2009. Transactions, that's the 5010, the compliance date for that was January 1st, 2012. And the ICD code set standards were delayed to October 1st of 2014. So you now have approximately 9 months to get prepared for the transition or to finish preparations. The code set adoption, ICD-9-CM diagnosis codes to ICD-10-CM diagnosis codes will occur in all healthcare settings. So that it doesn't matter whether it's inpatient, ambulatory care, emergency department, urgent care, nursing home, the transition will be in all healthcare settings from 9-CM to 10-CM for diagnoses or conditions. ICD-9-CM procedure codes to ICD-10 PCS is only for hospital inpatient services. And this is very important, especially if you are a clinic out there, because ICD-10 PCS is much more complex than ICD-9-CM. It's a different structure. It's just a whole new animal. So for hospital inpatient coders, their learning curve, they have to learn something that is totally, entirely new. In the ambulatory care settings, you will continue to use CPT and HCPCS codes to report your procedures. So that part of your coding in clinics will not change, which is very good news for you. And while 10-CM is quite a bit more detailed than 9-CM, the structure, how you use it, that's all still relatively similar. So your learning curve is not as steep as it was with, as it will be for the inpatient coders for procedures. The impact of the coding system change. So because ICD-10 is quite different from ICD-9-CM, it could be difficult to relate data coded under 9-CM to data coded under ICD-10. We expect this will have an impact on reports that compile statistical data for trend analysis. So for rating purposes, effectiveness of care, provider profiling, ad hoc reports you might use for immunizations, maternity, disease management. I expect all of your longitudinal data reporting will be affected. And I've done some studies on that, and I'll show you some results on that towards the end of this presentation. So you just need to be aware that that's one of the potential impacts. Other healthcare providers, non-inpatient facilities will only use ICD-10-CM, not 10 PCS. So Part B providers continue to use CPT. So what about if we want to map between the old systems and the new systems? CMS and NCHS have worked together to put together general equivalence maps between ICD-9 and ICD-10. And you can get to the maps via the CMS or via the NCHS websites. So those links that I provided you earlier, you can use to get back there. Backward and forward maps between ICD-9-CM and ICD-10-CM are currently available. Now, what that means is one of the maps goes from 9-CM to 10-CM, and the other one goes from 10-CM to 9-CM. As you might expect, when we're talking about going from 12,000 to 68,000 codes, the difference is the map is not a straightforward one-to-one crosswalk, because if the two classifications were the same and you could do a straight one-to-one crosswalk, then we wouldn't need a new classification system. The GEMs are not expected to equal crosswalks. They're basically there to help you see if you have code 250.00 in ICD-9-CM, what are the potential codes in ICD-10-CM. There was also a reimbursement map was added to the CMS website in 2009. This map is intended for use by payers as a temporary mechanism to allow claims to be processed by legacy systems until internal systems have been fully converted. It is important to note that these maps should not be used for coding actual medical records, but rather as a guide to translate data. Okay? So again, this one is focused on reimbursement, where the other GEMs are all possibilities, more clinically oriented than reimbursement oriented. And here's the CMS website for the GEMs. So who is this going to impact? It's going to impact everyone, as we've said, in all of your providers, your health plans or payers, third-party administrators or employers, and a lot of others, including public health, your registries, any vendors or clearinghouses, as well as patients who may have become used to seeing their data represented with ICD-9 codes, and now that's going to be converted to ICD-10 codes. So it's really a very broad change for the United States. Okay? So you're going to have to make the change, and you're going to have to make it soon. If you haven't started, what are some things you should be doing? You should be performing an impact analysis that's looking at everything in your organization to determine what might the impact be. Especially what might it be on operational processes where our coders might now have to take longer to code records, or our physicians might have more codes to choose from, so it might take them longer. So you really need to understand within your organization what might the impact be. Are you doing internal and external reporting? Will that have any impacts? And again, the clinical documentation, and I'm going to give you some hints about that towards the end of the presentation. Conduct a systems inventory, all databases and systems applications, including interfaces that use ICD-9. So if you have an EHR, of course that would be your EHR. They're supposed to be converting. That's a part of the EHR meaningful use, but you want to verify that they can handle the ICD-10 codes. Any other systems changes? Do you have other interfaces, like maybe with a hospital or a laboratory system or something else that uses ICD-9 codes, and you want to check to make sure that they're ready to go to ICD-10-CM effective the 1st of October. If necessary, request documentation from your vendors about how they're getting ready for the change. Perform a gap analysis on the areas of impact, and then how can you approach it and identify and rank your risks and create any contingency plans. So for example, you're definitely going to want to file your claims. Handling denied claims might be something you can put off a little bit, but on October 1st of 2014, you're going to want to be able to file your claims. So look at what's most important to your organization. So again, the inventory, obviously with health information management or whoever does your coding, they're going to be impacted. Are they ready? If you have a contractor, are they ready? Billing and financial, are your financial systems ready? Reporting, if you're doing any quality measure reporting to anyone, are they ready? And then the other support systems, again, with any ordering, clinical reminder systems, maybe checking your CPOE, if it's using ICD-9 codes as a trigger that your CPOE has been converted to use ICD-10 appropriately so that you're not placing your patients at risk. Determine the required software changes. does the field size need to be expanded? So we're going from 5 digits to 7 digits. It's got an alphanumeric composition now that's very different from an ICD-10-CM that's very different from ICD-9. The use of decimals, we have more trailing characters behind the decimal now in ICD-10-CM. Obviously the code values are redefined because they're structured totally different. You have longer code descriptions. Just everything that technically makes a data element what a data element is. You can't just rename the ICD-9 field to ICD-10 and expect that it's going to work. So establish an implementation timeline, which now would be very short. I do know larger organizations that have been planning for the conversion ever since the proposed rule was announced in 2009. Identify any resources that you're going to need and then manage it like a project where you monitor the timeline and update as necessary. Perform a detailed assessment of current day coding staff knowledge. Because ICD-10-CM is more detailed, it requires a more in-depth knowledge of anatomy and physiology than coders may be used to using. There's a lot of online training that's being made available with updating anatomy and physiology now for your coders through the Texas Health Information Management Association, the American Health Information Management Association, and other organizations that are working to help ensure people get trained. Who needs to be trained and what level, and how are you going to provide them training? And again, I've got some resources at the end of the presentation for you. What's your budget going to be? What do you expect it's going to be? You may want to consider, are you going to do any outsourcing? Are you going to do any temporary staffing? If your coders or your front office staff are going to be slowed down with the transition, how are you going to backfill so that your operations keep running? Are you going to do any testing? So some people, again, larger organizations are starting to test now. And after the rollout of healthcare.gov last year, CMS changed its mind about testing and has announced that they are now going to be doing testing. So is that something you want to participate in to ensure that your claims will flow unimpeded come October 1st of 2014? Contractual changes. So review your vendor and payer contracts, especially if codes are involved in any of those. So make sure your vendors know that they have to have you up and running. If you've got payer contracts that are somehow ICD-9 code specific, make sure you're getting those updated and including the vendor fees in your budget. And then start implementing, testing, and validating, develop and modify any policies and procedures, and assess the impact on the workflow so that you're not caught off guard with how it's affecting your operational processes. Identifying the major areas of change between 9CM and 10CM that impact data comparison is very important. And again, I'm going to have some examples of a study that I did. But it is also very organizational specific. So what the endocrinologist is going to see is going to be different than the family practitioner, than the oncologist. So just ensuring that you're aware of what the impacts on your data might be is very important. If you've got anyone who's going to be working on data conversion, go ahead and give them the links to the GEMs and have them start looking at those. Again, those are downloadable. They're publicly available and downloadable, so it's not something that you have to pay a consultant to get that data for you. So, clinical documentation recommendations. Organizations need to assess the clinical documentation and assess gaps and identify any gaps. And I recommend personally that you approach it as a quality improvement project with general improvements needed for clinical documentation, where queries can be used to address specific clinical documentation improvements needed. And Again, if you're in a little bit of a larger clinic, you can conduct educational sessions for staff where you're focusing on your high-impact diagnoses. So you can't eat the whole elephant, but what are the diagnoses and the codes that contribute most to your bottom line, and then that's where you would start looking at with the GEMS. If it's code X and it maps to code X2345 plus X2356 and some other codes, what's the documentation to make sure we can get to those codes appropriately as needed? So again, plan, do, study, act, who, what, when, where. So the do, educate your clinicians, make sure they understand, gather data for the specified ICD-10 changes that will be most impacting your organization. So the who is physicians and others who document in the record, and the what is improve clinical documentation for more general issues, which may require initial data collection. When you'd like to do the improved documentation at the point of care, it's always harder and more time-consuming, more resource-intensive to go back, and again, in all of the settings. So the check study, what were the results versus your expectations? What were the lessons learned from that? And then based on your check and study, do you need to modify your processes and repeat as necessary? So results versus expectations, you're not going to see total improvement all at once. It's going to happen over time. We've got some data about that. I don't think I've included it in this presentation, but we do have some data about productivity and about accuracy over time. And the results are actually pretty nice that within about 6 months it gets better, but that first 6 months is probably going to be pretty hard. So what do I see as candidates for the quality improvement or the documentation improvement process? Number one, laterality, okay, because we don't have laterality in ICD-9-CM, but we do have it in ICD-10-CM. So I would expect fairly quickly that they will no longer accept codes for injuries to limbs or bilateral organ conditions without laterality. Everything in your body that has laterality has 4 codes in ICD-10-CM. It's got right, left, bilateral, and unknown. And I guarantee you unknown is probably not going to be accepted. Okay? And again, your paralytic syndromes, they require right, left, dominant, non-dominant. Infectious organisms are a big one. We've seen it a lot in ICD-9-CM. How can we get our documentation, our processes, to where we can start including the infectious organisms in our documented diagnoses? That's a big one where we see a lot of unspecified diagnoses. Other candidates for the quality improvement or documentation improvement process would be injuries. There's now a 7th digit in ICD-10-CM, and it's this alpha digit, and it's where they're wanting to track, is it A for initial encounter, okay, so initial treatment in the ER, surgery, a new clinician. Is it D for subsequent, so healing or recovery, such as a cast change or aftercare, or S for sequela, which are complications or conditions such as scars or frozen joints. And this is something that we probably often know, but whether or not we document it is an entirely different issue. So this would be something, if you see a lot of injuries in your practice, where you would want to start now saying, let's document, is it initial, subsequent, or sequela? With fractures, fractures are much more detailed in ICD-10-CM. Obviously, open, type of open versus closed, routine versus delayed healing, non-union, malunion, many others, transverse, comminuted, spiral, just essentially all types of fractures. And the way they came up with this is they sent the CM recommendations to the orthopedists, and this is what they came up with. So very, very detailed. If your practice deals a lot with these, or an ED or something like that, you're going to want to start ensuring that the fractures are described in detail. Okay. Obstetrics, 5th and 6th digits are used for the trimester. So again, getting more detailed with the different codes for the different conditions. Coma, they want to know a lot more about the coma. So did you have any kind of response? Were the eyes open? And where? Where did they go into the coma? So detail that I think in many cases we haven't been collecting. Cardiac arrest. In ICD-10 we only have one code for cardiac arrest. In ICD-10 we have 3 codes. And so you can no longer just say cardiac arrest. What they want to know in ICD-10 was it a cardiac arrest due to underlying heart condition or cardiac condition? Was it a cardiac arrest due to other underlying condition, or was it a cardiac arrest unspecified? So they're really trying to get more detailed data so they can figure out more about the patients and understand more about what's happening with the patients. And then this is the last one is an interesting one, that adverse effects now include underdosing. And they don't really give you any clue about how to determine whether or not it was underdosing. I guess clinically, that would be a clinical decision you would need to make. But they do now consider that an adverse effect in terms of medication use, not just overdosing. So if I were in a practice or an organization and I were helping them prepare for this change, the first thing where I would start is I would start with my top 20 high volume conditions and treatments, and just simply run a random sample to determine whether the documentation is adequate for ICD-10 or whether we need more detail. I would also look at my top 20 high value conditions and treatments because they may not be the same. And again, randomly sample if you have enough cases to determine whether your documentation is up to snuff for detailed coding within ICD-10 CM. Clinician-specific efforts, depending on how many clinicians you have in your organization. So track the use of unspecified codes by clinician. Is it appropriate or not? Only you can answer that. Look at random coding of records in ICD-10 CM to determine the adequacy of the documentation. Use evaluation criteria that you've previously agreed on, and then provide feedback so that hopefully the documentation can start improving prior to October 1st of 2014. I've got a couple of query examples that I've included in the slides, and of course this is one that I've already made reference to, which is the diagnosis listed as cardiac arrest. It's noted in the H&P that the patient has type 2 diabetes without complications. Based on your clinical knowledge, can this case be further specified? So is it due to an underlying cardiac disease or due to other underlying condition? I think you'll probably find that insurance companies may accept general cardiac arrest for a little while, but probably not for too long. So you want to make sure that you're getting your documentation detailed enough. Second example, patient is admitted with an acute GI bleed, and you see there they receive a transfusion. Anemia, just simple anemia is documented. Okay, so but we noted the drop in the hemoglobin and transfusion. Can it be further specified? So that it's post-hemorrhagic, chronic blood loss, or other. The third example, the patient contracted an infection following a procedure, but no procedure was performed, but they listed it as a post-procedural infection. Okay, so then that becomes, is it the infection following a procedure initial, subsequent, or sequela? and that's where your clinical decision comes in from the physician. And by the way, in ICD-10, this one is simply other postoperative infection and no other detail is needed. So this is a perfect example of where you really do need, you really do have more detail in ICD-10, and so there's going to need to be that additional documentation. The fourth example and the last example, the physician listed atrial AFib, atrial fibrillation. It's the fourth admission to this facility. Multiple admissions are noted. Can it be further specified? Paroxysmal recurrent episodes self-terminate in less than 7 days. Persistent recurrent episodes last more than 7 days. Permanent is an ongoing long-term episode. So again, in ICD-9, we only have one code for AFib, which is 427.31. So this is another example where you just have more detail, and you've got to have that additional detail in your documentation. So moving on to productivity, and the study that I'm sharing with you is a study of inpatient coder productivity. There has been a study done on ambulatory care productivity, but those results have not been released yet, so I was not at liberty to share them with you. They'll be discussed for the first time at the AHIMA ICD-10 Coding Summit in ICD-10 Summit in April. So look for press releases and other announcements coming out of AHIMA at that time with those results. This one is ICD-9-CM compared to 10-CM and 10-PCS. And so if you're ambulatory care out there, that's important for you to keep in mind because, again, the 10-PCS is so very different. And you can see these were results that sort of shook the coding world at the time that we talked about them, because previously people had been saying expect a coding productivity drop of 50%. And we found a coding productivity drop of 69%. I will say that the ambulatory care coder productivity drop that we've seen was actually closer to 10%. So without giving you actual details, but that's a little hint that ambulatory care, if all you're doing is making the move from 9-CM to 10-CM, we expect the productivity drop for trained coders to be much less on the ambulatory care side than the inpatient side. So coder differences, and I provide this to you because we really tried to find what was that silver bullet that was going to tell us why a coder had, which coders had the largest productivity drop, and was there something we could do so that, we could reduce the coder productivity drop. And the short answer is there was nothing. We looked at it from trainer certification to trainer certification and basic training, and there was actually a difference there where of about 3 minutes. So depending on your, so that shows, I think, just that more training is better. Also, more practice would probably be better, so that's something for you to look at in your organization. But in terms of it being statistically significant, between the two, between the certification or the basic training, it was not. And the basic training was essentially about 10 hours spent learning ICD-10-CM. That was it. More coder differences. We have the high school associate degree, bachelor's degree, and even one master's degree, and nothing clear, because the high school's coder was almost as fast as the master's degree coder. Level of experience. The 3 coders who had 16 to 20 years experience were the ones who took the longest. So there was really nothing in this study that we could hang our hat on in terms of which coders are going to be faster and which ones are going to be slower. We did run inter-rater reliability statistics where we compared the codes that were chosen across all the records between all the coders. We essentially, our coefficient for that came out, it was a minus 0.424, and it was statistically significant. In essence, what this tells us is that as the time spent per record increases, the coding quality decreases. So if you come across a hard record or a difficult record, one that's taking you some time, you need to set a limit. If typically an ICD-10 record on average only takes you 15 minutes, then you probably shouldn't spend more than 20 minutes on it. You certainly shouldn't sit there and with the coding and spin your wheels, because you're not getting any gain in quality. You either need to ask someone or you need to assign a code and move on, because our study showed you that your quality was not going to increase the more time that you spent on the record. In fact, it was actually going to decrease because you're just second-guessing yourself. Okay. So the implications for that study was that the previous estimate of 50% initial coder productivity loss may be understated. Again, for the inpatient side, do expect some return on investment from training. We couldn't identify a perfect ICD-10 coder. We also couldn't find any relationship between their current speed in ICD-9-CM and their speed in ICD-10. And again, more time spent on a record does not translate to higher quality. So getting close to the last part of this, I've done some studies on comparability factors or ratios, and this is what you would need for longitudinal data comparison. I used as sort of my guide in the studies that I put together a study that came out of the CDC in the late 90s when they converted for cause of death for mortality from pure ICD-9 to pure ICD-10, and they came up with comparability ratios. So I went back and used that as the template for doing the study that I've done. What's essential is that you have to dual code the same set of records. So in order to get comparability ratios, they have to be the same records that were coded in ICD-9 and then were coded in ICD-10. And then you apply, between the ICD-9 and ICD-10, you apply the formula that you see on the screen in front of you. Okay? So what did I find? I found some really low comparability ratios. You can see nicotine dependence unspecified, heart failure unspecified. We have less than half of the ICD-10 cases that we found in ICD-9 for heart failure. Okay, so some really significant differences between ICD-10 and ICD-9 using the same set of records that were coded using both classification systems. More results. These were the ones that were over, and notice down here at the end where you have the J44.9, the chronic obstructive airway disease not otherwise specified. You actually have almost 20% more cases than you had in ICD-9. So again, your longitudinal data is probably going to take a hit. Had some where we had one-to-one matches on the data where they simply agreed for hypotension, for hypoosmolality and hyponatremia, UTI site not specified. Those were one for one. And here are more conditions with very little or no change. So some will be close, and you'll have some that are far off for the comparability ratios. So let's look at some of the conditions with the largest difference. So here is nicotine dependence unspecified. Approximately 91% of the codes were assigned to 305.1 in ICD-9, which is simply tobacco use disorder. But notice here in ICD-10, here it's unspecified, and here it's cigarettes. Okay? And so the question is, do you really not know, are you not taking a good enough history that you don't know why your patients are nicotine dependent? Okay? So back to the documentation, and not just that we're using any old code, but that we're documenting why they have nicotine dependence, whether it's cigarette or chewing tobacco or whatever it might be. Heart failure unspecified. So mentioned this one previously again. It takes us 4 codes in ICD-10 to only get to 87% of the cases assigned to 428.0 congestive heart failure unspecified. There is no separate CHF unspecified in ICD-10. So all of the cases that you have in ICD-10 are that you have in ICD-9 that go to 428.0 CHF, they have to go somewhere else in ICD-10. What about that AFib that we were looking at? So the 3 ICD-10 codes got us to 101% of the codes assigned to 427.31. So again, that additional detail, and you can see that if you're trying to track your AFib patients, you would have to use more than one code. There's actually another type in ICD-10-CM. Major depressive disorder single episode was one of those that was more than, it was 1.11, 111% of the cases assigned to 311. ICD-9-CM has more codes. They have 309.0, 309.28, and then 311 depressive order. So more things are grouped into the F32.9 code than in ICD-9-CM. Chronic obstructive airway disease. This was really surprising to me the first time I saw it, because I was like, 10 is supposed to be more detailed. Why are we winding up with this huge number for chronic obstructive airway disease? And it's 120% of the codes assigned to 496 chronic airway obstruction NEC, or COPD, that we see in ICD-9, but the ICD-10 code includes, again, additional conditions, asthma with COPD, chronic asthmatic obstructive bronchitis, and so forth. So you can't make presumptions or assumptions about which way the data is going to go. And if you were a provider that had contracted with a payer and you were supposed to keep your COPD patients to a certain number or a certain percentage of your patients or something like that, this should be of concern to you. So bonus findings. I ran the Joint Commission core measures. I'm still waiting for AHRQ to come out with their patient safety measures. But any kind of external reporting that you do, the longitudinal nature of the data is going to change, and it's going to change significantly in some cases. So I have almost 4,000 duly coded discharges that were recoded for financial purposes, but then they were de-identified, and I was able to use them for this longitudinal study. Joint Commission came out on July 2nd, 2013 with their National Hospital Inpatient Quality Measures. I used the codes that they identified for each quality measure to come up with the results that you're going to see on the next couple of slides. So again, we see for AMI that it's at 130%. Oh my goodness, if you're being measured on your AMI patients, you've got a problem. You need to know that what looks like this sudden increase in our AMI patients, in our cases, is actually due to the change in the classification system. All right, because remember, you're looking at the comparison for ICD-10 to ICD-9 on the same cases. Okay, so you would think it would be a lot closer. All right, so these differences can be attributed solely to the change in the classification system. So these were the exact same cases. No one changed their care. No one could change their care. All right, and you see here on this slide we go down to ischemic stroke, which is right at 75%. It gets worse on the next slide, where it goes from hemorrhagic stroke at 70% down to respiratory respiratory failure at 27%. And you need to understand that this hospital didn't all of a sudden get better in how they treat their respiratory failure patients. They didn't suddenly have any kind of change in respiratory failure, because these are the same cases. So the difference in the quality measures in the Joint Commission core measures between ICD-9 and ICD-10 that I'm showing you is solely due to the change in the classification system. So it's really, really important to understand the impact of the change on your longitudinal data. So what, okay, hopefully I haven't scared you. What should you be doing to get ready? So we've known this has been coming for a long time. Luckily, the Medicare Learning Network has a bunch of training that's out on YouTube, and I've given you links to those. The first one is probably about 35 minutes long. The Navigating ICD-10 and the ICD-10 Training for Small Physician Practices, they're each like about an hour and 20 minutes long. But I did look at them, and they were very informative, and so that's something I would recommend. AHIMA, the American Health Information Management Association, has specially developed online physician and clinician training. So, and they actually do it by specialty. So if you don't need to know all of it, if you've got, if you're a specialty clinic, a surgical clinic, or again an endocrinology or ophthalmology or something like that, they have 3 introductory modules that they recommend for everyone. So how to use the platform, documentation for ICD-10, a review of the curriculum, and then you can choose from specialty training modules, and they're meant to be really digestible to help you learn about the change in the system. Other implementation resources can be found at the AHIMA website. They have a whole section of their website that's just devoted to ICD-10. They have an implementation toolkit. I've given you the link to that. And they have a preparation checklist, so you don't have to create your own checklist that you can use to help you work through this process. If you haven't started, or if you've started and you want to know, am I covering everything? There are tools and checklists out there to help you with that. And with that, I think we probably have about 10 minutes left if there are any questions. So thank you for your attention. Here's my email if I can be of any assistance.
Thank you,
Thank you,
Dr.
Veronica.
Fenton. Thank you. I don't see any questions. In the meantime, I want to thank our speaker for taking the time out of her busy day to share her knowledge with us. Let me show my screen. If you have any questions for today's presenter, please email TexasRec using the email shown, and we'll make sure you get an answer. Please join us next month for our next educational webinar in the series. We will be presenting audits, the pre- and post-payment audits. It is going to be on March the 5th. Hope to see you there. There's one question. It says, how much time do you think we should spend educating the physicians at a minimum?
So the organizations that I've been talking to who are having to educate lots of physicians are generally setting aside about a half a day. If you're doing things like converting encounter forms or selection lists in your electronic health record or things like that, that will probably require more physician involvement, but that's not specific training. That's trying to ensure that the tools are ready when October 1st comes. So I would say a half a day.
Okay. I see another question. How can we get a copy of this packet?
Of the slides, Veronica is going to convert them to PDF, and I've given her permission to distribute them in PDF form.
I don't see any other questions. Well, thank you for attending today's webinar. Thank you very much, Dr. Fenton.
Thank you.
Okay, goodbye.